You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Clara Beaver, an Oncology Clinical Specialist at the Karmanos Cancer Institute in Detroit, Michigan, and member of the Metro Detroit ONS Chapter. Today we'll be talking about issues in care coordination experienced in patients with advanced and metastatic urothelial cancer. In December 2020, we released a podcast on treatment advancements in urothelial cancer. To listen, click the link in the episode notes. Seagen Inc. provided support for this podcast episode through an educational grant. Thanks for joining me today, Clara.
Thanks, Stephanie. Glad to be here.
Clara, clinical trials are an important part of oncology care and the advances that we see in oncology treatment. Can you tell us what clinical trials are available for urothelial cancer treatment?
There's a lot of clinical trials out there for urothelial cancer treatment. There's a lot of them in different phases right now. One example is a current first-line treatment study that's looking at pembro versus lenvatinib versus pembro versus a matching placebo. That's just one example of a lot of different trials that are out there. Again, the best way to search for these trials is to go to clinicaltrials.gov or go to the NCI Cancer website. They do have the trials listed, or you can go to your local organization and see what trials they have available. We're lucky here at our institution to have an app for providers and patients to look at different trials that we offer so that they can actually go online and look at those.
Thank you for those resources. That's a great way for oncology nurses to be able to not only see what's available for their patients maybe before they even start, but for them to go on once a patient does start. Because my personal experience has been that sometimes as the treating nurse, while you do everything that is on the clinical trial, sometimes you don't know all the specific points about that trial. And it would be a great way for those treatment nurses to be able to find out and understand exactly what is part of the trial, especially if you might have to do those special drug level blood draws and things like that go along with clinical trials so often.
Yeah, and I also think that having patients aware of the clinicaltrials.gov site, it's a great site for them to go to see what trials are out there that may not be local for them, but maybe within a distance that they can get to. They're great resources, not only for the staff nurse, but also for those patients to be able to just take charge of their care and figure out where they're going to go.
That's a really good point. And I think patients now are so internet savvy to be able to do that and then come back and ask questions of their providers. But also, people are so transient in where they live or willing to go somewhere else, especially if there is another option for treatment for them at another center that they might qualify for a trial. So that's great information. So let's talk now about some of those treatments for the patients with advanced urothelial cancer. What are some of the issues people experience when they're being treated?
So like many patients that are receiving chemotherapy or surgery or radiation, they have those myriad of side effects. But how we really find out a patient has advanced or metastatic urothelial cancer is really pain. It's that sign that the patient has. So they may have had urothelial cancer and had some bladder issues and they've lived with that, but now all of a sudden they're having bone pain or they're having malignant pleural effusions or urinary obstructions that they weren't having before. Those are really those signs that we look at for these patients and that they may have advanced. And so then the physician will order some scans for those patients and then look at those scans and discuss with the team the best approach for the patient. And then review those with the patient and come up with a plan of care for the patient of what the next step of therapy is going to be.
Well, in July 2020, you did a podcast episode with us on intravesicular chemotherapy. Is that treatment used for advanced disease?
No, intravesicular therapy is not used for advanced or metastatic disease. If you think about how intravesicular therapy is given, it's given with the chemotherapy agent going directly into the bladder and sitting in that bladder, attacking those cells that are in the bladder. When a patient has advanced or metastatic disease, urothelial disease, that is now outside of the bladder. It can be in the bone, can be in the bloodstream, can be in lymph nodes. And so just giving the chemotherapy into the bladder is not going to attack those other cells that are outside of the bladder. Also, a lot of these patients have no bladder because that's part of the treatment for those patients. So again, that intravesicular therapy would not work for these patients.
That was a very good explanation of why that would not be a treatment that is used with these advanced diagnoses. So what type of treatments or regimens are options for patients with advanced or metastatic disease?
So we use chemotherapy, immunotherapy, and targeted therapy. So if we look at the chemotherapy agents, we use cisplatin, Gemzar, carboplatin, doxorubicin, methotrexate, vincristine, and mitomycin C are the most common ones that we use. For therapy, we use Pembro, Nivo, and Tuzaluzumab. And then for the targeted therapy, there is a new drug that just got FDA approved, which is an oral agent called erdafitinib, which is used for patients that have an FGFR3 or FGFR2 mutation and have failed platinum-based therapy. So we are continuing to look at different agents that we can use for these patients.
I can see where you were talking about the chemotherapies that are available, and those names are all very familiar, I'm sure, to our listeners today. Those are really classic, as comes to mind when I hear those different names of the chemotherapies. But as with everything else in oncology care, the new treatments that are coming out and how fast they're coming out and how fun they are to say, just the names and unfortunately how difficult they are to state and say sometimes, but they are definitely, it's great that we have them and that they are being discovered and that there are more options out there for patients even after they've failed. Like you said, some of those platinum regimens or some of those classic or the gold standard therapies. So what are some of the common side effects of chemotherapy treatment that these patients get, and how can nurses best support them during that time?
So as with any chemotherapy, it's the same types of side effects that we have: the nausea and the vomiting, the hair loss, the numbing and tingling in the hands and feet, constipation, diarrhea, having that fatigue related to chemotherapy. With the cisplatin, you can have the hearing loss or the ringing in the ears. We also look for decreased kidney function. The caveat of all chemotherapy agents, the low blood counts, the risk for infection, the risk for anemia, the risk for thrombocytopenia. All the same things that we see with all of these agents that we give. And really, the nurse's role in that is, one, to inform the patient what the side effects are, the possible side effects, but two, to really work with them on the self-care aspects of these side effects. Really, the education around what the patient needs to do when they go home is really important with these patients. They've had chemotherapy before, usually. They know what it's like. They've been through things. But again, just reinforcing with them what to do if they have continued nausea and vomiting, what medications they should take to help with that, or when to call. If they do have hearing loss or numbness or tingling in their fingers and toes, making sure that they let the physician or healthcare team know as soon as possible so that they can look at reversing those and changing agents for them. It's something patients don't always do because they don't want to be taken off treatment because it may be the only thing they think is going to help them get to the other side. Again, making sure that they're drinking lots of fluids when we're giving them things like cisplatin, making sure that we are trying to help their kidney functions. So again, just really those self-care concepts around all of these side effects. Now, with the targeted agents, we have a little bit different side effect management with them. The patients don't always have that nausea, vomiting, diarrhea that we usually see with our other chemotherapy agents. They may get them, but they also have a lot more fatigue or rashes is what we really see with the targeted agents. So making sure the patient understands that the rashes are common and that they need to call us, but there are things that we can do with it. And it doesn't mean we're going to take them off treatment, because we don't always take them off treatment when they get those. Again, they have a lot of the same things that we see with regular chemotherapy agents, but then there are also some things related to eye exams. Sometimes you may have some loss of vision or some changes in your eyelashes even, or in the dryness of your eyes. So making sure that the physicians are aware of those and the patients are aware of those. So again, the targeted therapies are a little different than the chemotherapies, but they still have some of the same side effects, but we may have more side effects because, again, that drug is actually targeting a specific surface on a cell, and it can attack the surface on our normal cells as well.
You're right about patients not wanting to tell us what those side effects are, because they are so fearful sometimes that they're going to be taken off of treatment. And what does that mean for them? And I think, as you said, the education to patients is so very important, that we get that information to them and really let them know and understand that our goal is not to take them off of therapy either. We want them to continue with their therapy, but that some of the side effects with their treatment could be harmful to them, and maybe a delay, which we don't like delays either, but it really helps us make sure that they're getting the best care and having the best quality of life during this treatment that they can have as well. Patient education is so important to get that across. What should be included in patient education when starting someone on some of the newer immunotherapy treatments?
So just like with regular chemotherapy, going over side effects with them is very important, because again, their side effect management is a little different than with chemotherapy. With immunotherapy, we're really ramping up the immune system. And if you think about it, it's more like giving a vaccine to the patient, right? We're trying to ramp up their immune system to either attack the cancer cell or bring other parts of our immune system to attack that cancer cell. So unlike normal chemotherapy, where we may see side effects right away or a few days later, usually the side effects for immunotherapy can happen within those first 24 to 48 hours. And what patients usually tell me is they feel like they have the flu. Again, like when we're ramping up that immune system, they may have a fever, they may have a rash, they may have some of the diarrhea or the tiredness is what really goes along with those immunotherapies, because those are the things that we're seeing as we're ramping up that immune system. But with the immunotherapies, what we've noticed is called itises. We have to look at those itises with those patients. The patients get pneumonitis. So if they start complaining of a dry cough or shortness of breath they didn't have before, it's worth looking at doing a chest x-ray on them to make sure they don't have a pneumonitis happening. They also can have colitis. So all of a sudden the patient's having some abdominal pain or blood in their stool or differences in their bowel movements. It's worth looking at to make sure they don't have a colitis going on. And then the other thing that we've been seeing is hepatitis. So the patients all of a sudden are having jaundice or, again, abdominal pain that they hadn't had before. So looking to see if a hepatitis is happening. So again, as we ramp up that immune system to try to attack the cancer cells, we do also ramp up other parts of our immune system that do cause side effects.
Those are all great things to know and to understand, to look for, because like you said, they're different than what some of the other traditional chemotherapy side effects might be. So for these patients with advanced disease, surgery is something that most likely would have already taken place, if I'm correct on that. What are some of the care considerations for patients who have been treated with surgery?
So if the patients had surgery previously, they've more than likely had their bladder removed. So they are going to have some type of urinary diversion going on. So they're going to have a urostomy or a stent or a neobladder, something that is now collecting their urine, which the bladder used to do. So we just need to make sure that the patient is comfortable in understanding how to handle that urinary diversion. And most commonly, it's the ileal loop. So it's usually a urostomy that these patients have, and that they understand how to take care of them. Now, again, most of these patients have had these for a while, but now they have advanced disease and maybe we're starting on different agents. And is there different precautions we need to take when they are receiving chemotherapy with the urostomy? Are there changes in weight or changes in the way that they are now handling their urostomy? So again, just making sure that we're supporting those patients in any of the type of urinary diversion that they have. Sometimes they may need new things like a urinary stent if they're having obstruction. So this is a new thing that they need to learn how to take care of, or a NEF tube, making sure that they understand how to take care of that. So again, just really assessing the patient's needs and making sure that they understand how to take care of it. We are lucky enough here to have a wound ostomy team that really works with our patients that have ostomies or urostomies or NEF tubes. They work with them to make sure they have the right appliances, they have the right equipment, and are there to help with them. So those are really great resources to be able to give our patients to understand how to continue to take care of themselves.
I'm sure that is a big resource for those patients. And it's such a big life change, even, and just how you care for yourself because of that surgery, and what patients and family members or their caretakers have to be aware of and have to understand the importance of that care and just how to do that, and for everyone. So we've talked a lot about the treatment. So we've talked about the chemotherapy treatment and targeted therapy, immunotherapy, surgery. What is the role of palliative care in patients with urothelial cancer?
So I can't say enough how important it is to have a palliative care or supportive team. We have what we call supportive care teams intervene with these patients early on in that advanced metastatic role. It's a new journey for these patients, especially if these patients have started off as just a urothelial cancer that is now advanced. And they are going through a new journey, right? There's no cure really for advanced or metastatic urothelial cancer. We can keep them alive for a while with chemotherapy and other treatments. We can try to keep their quality of life good, but they're going to start to have more side effects. They're going to start to have maybe some more nausea or some pain or some neuropathies or insomnia that the medical oncology team just can't get a handle on. So if we can get a palliative care team involved with these patients early on to help with those small side effects, things that they are very good at helping us deal with, we can also start to gain that trust with the palliative care team and the patient and the families, so that when we do eventually have to transition them to the next step of their journey, which may be comfort care, maybe hospice, maybe just palliative care where we're not any longer treating, they already have trust with that team. They're not coming into a new provider trying to learn who they are, or a new team. Most palliative care teams have maybe a social worker involved, have a psychiatrist involved, and then physicians that are and nurses that are really well versed in how to take care of these patients. Having that team up front working with these patients, again, is a great resource to have, not only to help with the symptom management, but also when we transition them over into that palliative care or that next phase of their journey.
I can't agree with you more about the importance of starting that palliative care team at the beginning, in the early stages. They're not just the end of life care team. They're definitely a team that works throughout the continuum of the patient's care. And I think it's so important, like you said, for them to have trust with that team. And there's already a relationship built. And so when you do have to transition into different stages in their care, that it's already something that's in place, that they're not feeling like you are giving up on them, or that you're just turning them over to someone who they don't know, and at a very difficult time in their process, and how important it is. And also just that it's such a great multidisciplinary team, like you were saying, with having the psych involved, and if they need social work help, or just all of those different aspects of not just their medical team, but the other multidisciplinary teams that help out with that. So that was really an important piece that you talked about. And talking about having that multidisciplinary team involved from early on and things like that. So many times in patients that have a cancer diagnosis, we are seeing, and I feel like it's becoming more frequent, or just something that we're actually talking about and feeling more comfortable in talking about, is the expense of these treatments and financial toxicity that goes along with these treatments. How can oncology nurses address financial toxicity in these patient populations?
So I think first and foremost, we just need to get comfortable talking about financial toxicities. It's like that sex talk. We're not comfortable talking about it because we don't know where everybody's at. So financial toxicities is real. It does happen to our patients. We frequently have patients tell us that they have to choose between their growth factor or their oral chemotherapy or paying the electricity bill. And how do you choose what you're going to do? So really just being comfortable to talk with the patient and understand where they are and what things they're having problems with. Making sure we're there to support them if they need FMLA paperwork for them or their caregivers. But even more important, talking to them about their insurance and encouraging them to call and talk to their insurance companies to find out what they are eligible for or what their out-of-pocket cost is going to be. Most people don't know what's going on with their insurance. I have no idea what my copay max is. I have no idea if they'd pay for travel for me to go back and forth to appointments because I don't need that. Most patients don't need that until they get a diagnosis of cancer or they get a diagnosis that's a long-term diagnosis. But with cancer treatment, we're having our patients come back and forth to the cancer center frequently. They have to travel frequently. They may have to take more time off from work. Their caregivers may or may not be able to take time off from work. So talking to the insurance company and finding out what they have available to help them, a lot of insurance companies have travel reimbursement for patients. They do have out-of-pocket max. So if my out-of-pocket max is $10,000 and my first 2 months of treatment takes that $10,000 out, I may be paying on that for a little bit, but I know the rest of my treatments are not going to cost me. And that can take a burden off from the patient and their families. So again, social work is a great resource for these people. If they have issues with financial toxicity, they usually have a myriad of things, but not all places are lucky enough to have social workers available. So what else do we have to offer our patients? Some institutions or cancer centers have financial counselors that are very versed in it, that are great to talk with patients. If you can't have that, look into the local community. A lot of times there's groups within the local community that can help, or even the American Cancer Society is a great place to turn patients to look to see if there's anything available. And we're talking about financial toxicities related to drug cost. A lot of the drug companies have copay assistance that we can offer our patients. Again, even going on the drug website and looking to see if it's available, or talking to drug reps, or talking even to pharmacists, because sometimes they know. Even that little bit of help, if I only have to pay a $10 copay for my drug as opposed to $500, that's a huge difference. And if we don't research it, we don't know. There are also charitable organizations out there that help patients that we can get information for them. Or a lot of times there are local cancer center fundings or other local funding for patients that are undergoing cancer treatment. A lot of people like to give money to help patients that are undergoing cancer treatment, whether it be through a local cancer center or a local area on aging, or even just some local doctor's office may have that information. It's always worth looking out to see if there's any funding available for our patients.
Thanks. Those are some great tips on other ways that we can help our patients address that financial toxicity. So what are some of the resources that you share with your patients? We've talked about so many different aspects of patients who have advanced urothelial cancer, about the nurses and how to support them, and about patient education. But what are some of those resources for patients?
So there's a lot of resources I give patients. When it comes to chemotherapy agents, I usually tell my patients to use chemocare.com. It's a great resource. It's written at a 5th grade reading level for our patients. They can pull up information about drugs. They can pull up information about side effects. There's a lot of great resources there. I also try to find if there's any local support groups for patients. Again, these are changes for them and for their families. So if we can find a support group that is able for them to be able to join, or just someone else to talk to, it's a great resource as well. American Cancer Society is another great resource for patients to go to find out information. Sometimes there's funding issues that they need to look at through there. And then also clinicaltrials.gov and the NCI website. All of those are great websites for patients to go and try to find information. And again, I just try to resource them to any of the local or organization-wide resources I have, whether it be social work or a dietitian or a wound ostomy nurse. I'm just making sure that they have those resources at their fingertips if they have any questions.
So I have one question for you as we finish this up today. What is something about caring for this population that's not often discussed, but you wish people knew more about?
So I think we don't often discuss how much of a burden this is on the families and the patients. For example, we had a patient that chose not to continue with treatment because he felt like he was a burden on his family. His family, only his daughters were local. The rest of his family was out of the country. And he just felt like he was being a burden because, one, he needed someone to bring him back and forth. Two, he didn't always know who to call if he had issues. So again, it is a change for these patients. They went from possibly getting a cure to now there's nothing else that can be done other than we can maybe prolong your life some while we're giving you these treatments. So again, the patients, it's stressful for them. It's stressful for their families. They're transitioning this hope to this stress of not knowing when the end is going to come, how the end is going to come, what's going to happen. And they don't always know who to call or who to contact when something comes up. If their ostomy starts leaking, do I call the clinic nurse? Do I call the wound ostomy nurse? Do I call the physician? Who do I call? What number do I reach? If they all of a sudden have a problem paying for some of their medications so they're unable to take them, who do they call? The pharmacy? Do they call the doctor? Do they call the nurse? So again, trying to give those patients as many resources as we can up front of who to call for whatever issues that they may have. I think that's really important to understand and know that it's a stressful time for the patients and the families, and they may just need us to support them and give them time to make the decisions. And it may not be the decisions that we personally would make, but we just need to be there to support them, give them the options, and give them time and support in what they need.
That's great. We definitely need to support our patients all the way through their journey with this. It is just such a life-altering diagnosis that they get when they get a cancer diagnosis. So, Clara, I just want to thank you for all of the great information and your expertise in this area that you shared with us today. And want to ask, do you have any final comments for us about caring for patients with advanced and metastatic urothelial cancer?
The only thing I can say is, again, like I said, just support these patients and families as they go through this stressful time. It can be stressful for our patients, it can be stressful for us because we don't know how we can help them. So it's just a different part of the disease process, getting palliative care involved early, making sure that we have all the support behind our patients that we need. And if you need help, reach out and ask somebody that may have a little bit more experience with it than you do. There's a lot of people out there that can help get resources for you.
Thank you for joining me today, Clara.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.